Okay, good morning. We'll go ahead and get started. Thank you all for joining us for our Northern Light Health's Good Health is Good Business Zoom conference. It is a pleasure to welcome you today as we celebrate the first week of spring, knowing that warmer weather is just around the corner, and I refuse to believe it's going to be any other way. Today, our discussion will focus on the older worker. As you may have heard, Maine is often referred to as the oldest state in the nation. According to Maine's Department of Labor report, in the last 30 years, the largest segment of Maine's population has moved from what is often referred to as the prime working ages of 25 to 44 toward later career or retirement ages of 55 to 74. While some may argue what ages truly define prime working years, there is no question that our workforce in Maine is older. With this shift, it is important that employers understand how they can best support the health and wellness of our older workers in their transition to retirement. I'm Karen Hawks, Vice President of Operations at Northern Light Beacon Health, and I'll be your moderator for the next hour. Please join me in welcoming our expert panelists today, Dr. Jim Jarvis, Senior Physician Executive at Northern Light Health and Director of Clinical Education at Northern Light Eastern Maine Medical Center, Dr. Clifford Singer, Chief of the Center for Geriatric Cognitive and Mental Health and the Director of the Mood and Memory Clinic at Northern Light Acadia Hospital, and Jay Pearl, Medicare Planning Specialist for Carroll Harper and Associates Incorporated. Before we get started with today's discussion, I will read our legal disclosure. The coronavirus pandemic is an ongoing and continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply in every situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. This hour is intended for you, and we welcome and encourage your questions at any time using the question and answer function. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences, so we definitely want your feedback. It is now my pleasure to introduce Dr. Jarvis, who has become a trusted source of information for so many of us. Today, I thought we would have a brief discussion about some of the latest news we are hearing about the COVID-19 public health emergency. So Dr. Jarvis, good morning, and thank you so much for joining us. As
Thank you,
always.
Karen. It's good to be here.
So Dr. Jarvis, the Department of Health and Human Services is planning to end the public health emergency for COVID-19 on May 11th, which is right around the corner. Can you speak to what major health policies that will impact and if there's any impact to Maine?
Yeah, that's a great question. So first and foremost, I want to say that the end of the public health emergency doesn't mean that we have eradicated coronavirus from the planet, nor are we not dealing with COVID-19 issues. We continue to see people who are hospitalized for COVID-19 across the state of Maine, including some that are severely ill and require intensive care. And unfortunately, we continue to have Mainers die and Americans die every day. Not Mainers die every day, but Americans die every day from COVID-19. So we're really transitioning, though. And so we think about a public health emergency on the federal level. Really what that's stating is that the federal government needs to come in and offer assistance to deal with whatever that public health crisis is. And for the last few months, really, most local and state authorities have really been the ones who have been responding to any kind of issues going on around COVID-19. And so that's the reason why the federal government at this point is going to end the public health emergency. What does a public health emergency do? It really authorizes several different departments within the administration at the federal level, gives them expanded powers, gives them funding in order to deal with things. And so all of that ends on May 11th. There will be some transition. There are some things that already have been extended. So there's been a couple of things here in healthcare, particularly things like a waiver for allow us to do telehealth in situations where we weren't allowed to do that before, to extend. The biggest things that the public, I think, will notice are really that very shortly after that, we may start seeing that things like testing for COVID-19, vaccines for COVID-19 go to the commercial market, meaning there may be a copay or a cost to individuals to access those particular services. And so that's something that it's still a little bit unclear as to when that will phase in and phase out. You may have seen in the news lately that there's some congressional discussions about Moderna and Moderna's pricing for what they think their COVID vaccine will cost once the public health emergency ends. And so that will be a strong concern. If they're talking about, a vaccine that was free for a very long period of time, and now all of a sudden costing people $150, $250 or more to receive those. Again, it's a fear that many of us in public health feel may actually make it so that people are less likely to get needed boosters when those come about. So those are some of the highlights that people will see almost immediately. I think the biggest concern to us here in Maine is the uncertainty about Medicaid or MEDICARE enrollment. For the last 3 years, the states have not been required to re-enroll individuals that are in Medicaid, or in our case, MEDICARE, on an annual basis like we had been doing for quite some time. That ends on that 11th deadline. The government has said that states have up to a year to determine when they want to do that re-enrollment process. Maine has not finalized their process, and there is concern that people will be confused or forget that they need to do that. We at Northern Light Health will be providing messaging as to when people need to do that. We cannot do that on behalf of patients. Patients must re-enroll in Medicaid or MEDICARE on their own. So that's a big concern. So I think those are the big policy issues that we really need to think about. There'll always be some other things that just come up because nobody thought about them until after the public health emergency ends. And so we'll try to keep on top of that and give that information out as we hear it.
Thank you so much, Dr. Jarvis. I think that MEDICARE change is quite significant for the state of Maine. We know that there was a big spike in participation because of that continuous enrollment. And so I think that's something for people to be very mindful of and aware of. And certainly if we know we have friends, families, community members, so forth that are on MEDICARE, they need to be prepared and pay attention to the messaging that's going to come up from the state for sure, right?
Absolutely. And I think that's important. And again, we will try to get messaging out as well to the patients that we serve, but I think it's important for everybody in our community to be aware of that.
So, Dr. Jarvis, with the end of the public health emergency, is it safe to say that the pandemic is over and that this is our new normal? I know for a couple of years, we were asking you to look into your crystal ball and tell us what new normal is going to look like. Are we actually living it now?
Yeah, so typically this is where I put my caveat in that we've never been able to be good about predicting things, but we've been in kind of the same setting here in Maine for over 6 months now. So our numbers are about the same. We're seeing about the same level of severe disease. That brings hope to me that yes, this is really where our new normal will be. It doesn't mean that a lot of things are going to change. I mean, it's not going to get all better all at once. The fear, of course, is that next variant that none of us saw coming that causes another huge increase like we saw with the Delta variant or the initial stages of the Omicron variant before we switched the vaccines for that. And then, of course, in public health, we always worry about the thing that we don't know, disease X. Coronavirus was the disease X of 2020. What will be the disease X that we deal with next? And hopefully we've learned a lot of lessons with COVID that we will be able to put in place. I continue to feel that Maine as a state did so well with our response, and we continue to talk about those partnerships on a regular basis, that if and when the next issue comes up from a public health standpoint, we will be ready to at least start the process to help Mainers.
And I agree. I am so proud of how Maine handled it, and I really do appreciate your leadership and role in that too, Dr. Jarvis. We do have a question, and I'll pose it now for you rather than wait. What happens with isolation and quarantine? Is that going to stay the same, or do you think that that will start to continue to, I would say, loosen?
Yeah, I think one of the things that could be a benefit coming out of the pandemic is really the way our business leaders and our business community have changed their practice. Americans have always been thinking socially about going to work regardless of the circumstances. And now we have really built into our practices that if you're ill, you need to stay home to protect yourself, but more importantly, protect everybody else in the community. I think that needs to continue going forward, that when we're sick, we need to stay home so that we don't spread diseases as rapidly as we had. As far as the guidance around isolation, if you do become positive for COVID-19, I don't see that changing because we really have backed off a lot of things, right? If you've gone 5 days since your positive test and you're doing better, on day 6, you can then go out in the community. We appreciate it if you wear a mask when you're doing that, as long as you no longer have a fever and your symptoms are better. That's a big difference than what we were saying before. I do think that there are still some certain settings where we will see some more isolation things. I think in healthcare, you're still going to see people wearing masks for a little while, at least in areas where there are more individuals at risk. So some of those things won't go away right away. And some of them are just really good common sense. Continue to wash your hands, continue to stay home when you're not feeling well, seek out medical attention when you're really not feeling well.
Well, thank you as always. We really appreciate you joining us month to month, every month, to give us your insights and information. So I am very pleased, Dr. Jarvis, to hand the mic over to you as you help us moderate the next session and introduce our next panelist.
Well, thank you so much, Karen. I'm delighted to introduce Dr. Clifford Singer. And Cliff, if you can turn your camera on now. Dr. Singer is a psychiatrist who specializes in geriatrics. He is the director of Northern Light Health Acadia Hospital's Mood and Memory Center, and he is a prominent researcher into Alzheimer's disease and treatment. He's also a friend of mine, and I welcome the opportunity to have this conversation with you. Cliff, thank you so much for joining us today. As many employers across the country continue to struggle to find new members of their workforce teams, one potential source is older Americans. This is particularly true in Maine, where, as Karen stated, we are the oldest state per capita in the country. And add to that with rising costs for everyone, including seniors, some are staying in the workplace longer than they had intended. Experience is definitely important to businesses, but employers and employees may be wondering if there is a point where in the normal aging process, this interferes with the benefit of experience. I know I'm going on 57, and I find I'm recognizing more times when it takes me longer to remember somebody's name, or I search more for the proper word. And so, Cliff, what are some of the things that are normal changes we see as someone ages?
Well, first of all, thanks for the introduction, Jim, and for inviting me. Older adults are really actually more diverse than any other age cohort. Plus, there's we age differently and become less and less alike, actually, as we get older, although there are truly some universal aspects of aging that affect most people. Plus, you have to divide people or think about people as young old and old. We're mostly going to be talking about people in the workforce, so we're mostly talking about the young old, but truly there's some old people still in the workforce for various reasons. Okay, well, that being said, there certainly are some generalities that apply to most people, and you've even alluded to that. Starting in midlife, people notice that they're having more trouble recalling names and nouns, and that's been well studied and documented. As people age, they're less efficient in multitasking. They can't switch from one task to another quite as quickly. They may need more repetition to learn new skills. All this is pretty normal and not predictive of developing dementia. This is all, it's frustrating, but normal and really not anything to worry about. You just have to accept it and make the adjustments.
Are there things that people can do that can help slow those normal changes, or at least better prepare them for them?
Well, yes and no. There are genetic influences for some of these cognitive changes, for all the changes associated with aging. But there are definitely some modifiable risk factors. And most of us, I think, know what those are for cognitive decline and dementia. They're actually similar to risk factors for cardiac disease. So there's family history, there's diet, there's sedentary lifestyle, there's sleep deprivation, high blood pressure, chronic stress, hearing loss, and social isolation. These are things that sort of rise to the surface as major risk factors for cognitive decline. Also, education or low education is a risk factor, and high education is a protective factor. And so, in a sense, we're all protecting ourselves today by trying to learn new information. So staying engaged in the workforce, really, you can kind of think about that as decreasing your risk for cognitive decline, because it allows you to stay socially engaged. It allows you to feel relevant, and you're learning and maintaining skills.
Yeah, that's great. And in my own practice with my older patients, I often talk about things like social isolation and ways that they need to find a way that they continue to communicate. And oftentimes it's not just communicating with their spouse, because that becomes repetitious for them, and trying to find some other new ways to kind of get out there and do things. The other thing I always recommend is, if you're not doing anything that's a skill set, to find a new skill set. So whether that be a hobby or working on puzzles. I myself now do my Wordle every single day so that I keep using my brain to do that. So very good. Well, as an employee, when should I be worried that maybe what I'm seeing isn't just normal aging and I actually may have an issue with cognitive decline?
Right. So, developing dementia is usually a slow and insidious process. And in the beginning, it's easy to shrug it off as normal aging. And in fact, what we call subjective cognitive impairment or subjective memory impairment, where a person is aware of and frustrated by changes in themselves cognitively, that's generally benign. But when it gets to the point where it's really noticeable to others, a person probably should be evaluated. Now, it may just be stress, sleep loss, depression, or a medical issue. But it probably should be evaluated by a healthcare provider. Now, there are some particular signs that are especially worrisome, like getting disoriented while driving in familiar places. That may be an indicator. Having to hear something 3 or more times without remembering it. But things like forgetting where you parked, forgetting someone's name, or being slow to recognize somebody's face, these are pretty normal and not necessarily predictive of cognitive decline.
So now the $1 million question, when should we slow down or stop working? And is there some way to discuss this with our employer to help ease that transition?
Well, there's definitely a difference here between work that's physically demanding and work that's cognitively demanding. In both cases, adjustments to work demands and work hours may be necessary to keep somebody in the workforce. Resentments may develop between coworkers if someone is perceived as getting special treatment because of an age-related disability, but that can be actively managed, and people can and should hopefully be aware that having older coworkers in their workforce actually makes their life easier, because we are increasingly reliant on older people to fill out our workforce.
Well, thank you for that very useful information. Now let's look at things from the employer's standpoint. It's often easy to know when someone cannot perform the physical tasks of a particular job role, but employers may even bring this up as part of a request for an accommodation. But many are reluctant to discuss cognitive decline affecting performance. Are there things employers might notice that hint that an employee may be having issues with cognitive decline?
Yeah, well, we've talked about what's normal. What's really not normal is confusion. That's definitely a bad sign. It's not a normal part of aging. So, confusion about workflow, confusion about how to get something done, confusion about where things go in a familiar, well-rehearsed, well-known work setting, that's a call for an evaluation.
So how do you go about approaching that, either in your work environment, or how would you coach somebody else to go about that?
Well, from a personal perspective, I'm really lucky. I work with young people who are very patient with me. They're used to me asking, did you tell me that already? They tolerate me because they trust my judgment. They rely on my knowledge and my skills. And actually, they ask me a lot more questions than I ask them. From a professional perspective, I encourage people to work as long as possible if they want to, and if they can still contribute to work. It has to be considered on a case-by-case basis how long a person can continue to contribute to their job and their profession. But with adjustments of expectations and demands, people can generally work pretty far into life, into late life. And as a society, we really need that because there's a shortage of younger workers, number one. Number two, people need to stay engaged for their own well-being, financially and personally and cognitively. So if people want to continue to work and there's flexibility in their work environment, then they should be encouraged to continue.
So you and I have spoken many times about assessing the workforce, particularly the physician workforce, for cognitive decline. We look at this from a patient safety standpoint in our profession. Some healthcare systems have gone so far as to require some form of cognitive testing based upon some age, 70, 75, 80. What do we know about these approaches and do they work? I will remind everybody that we are not giving any legal advice here, but only what we know as healthcare providers. So Cliff, what are your thoughts on that?
Well, you're right. I mean, some professions, classically airline pilots and traffic control personnel have mandatory age retirements. Medicine is a little different. Traditionally, we've encouraged people to work as long as possible. People are generally good about recognizing when it's time to quit. But sometimes ego can get in the way. Also, people can lose insight into their own cognitive decline. So some healthcare systems have instituted mandatory screening, but age-based screening is viewed as discriminatory. It's very controversial. It's been challenged at some systems that have implemented age-based screening, cognitive screening. And age-based cognitive screening is very difficult to implement. Additionally, some screening methodologies may not translate well to actual day-to-day function in the workplace. So what are you actually measuring? In the case of medicine, there's also crystallized or deep knowledge that people can contribute, even if they are starting to have some memory issues. So we've chosen not to do screening and to try to support our aging workforce. We need them, we rely on them, and we use a peer review process to identify problems if they emerge. So yes, surveillance and performance review are necessary, but systems can make adjustments to allow people to be productive for as long as they want to be.
And that dovetails right into my next question is, what can employers do to assist their employees and keep them safe and productive?
Well, flexibility is key. We have to remember that losing the wisdom, knowledge, and experience of older workers is very expensive. There's a lot invested. We have invested in older workers. And losing them affects the culture for the worse. We need to accept that older workers can and should stay in the workforce if they want to, with reduced schedules, perhaps different task demands, work partners to help them overcome some barriers, often technical barriers. These kind of adjustments can and should be made, and they can benefit the business argument because of what older adults can contribute, and how expensive it may be to replace that experience that they have. There's an institutional knowledge and professional skill that is really takes years to develop, and so losing that is it's a big loss.
Thanks, Cliff. We have a few questions from our participants. So I'm going to ask you just a couple of them. One was, does over-the-counter memory pills work? We continue to see commercials for, hey, I never remembered anything, and now I took this pill and miraculously I am a genius.
Expectations can affect performance. That's why ageism can make a person more forgetful. If you believe you're old, you may actually act older. So there's certainly a placebo effect at work with cognitive enhancing agents that people may buy. A few of these supplements have plausible scientific merit, but are not well studied, and and they can be expensive. So I would say the evidence is not strong. Most of these things appear relatively harmless, but they may not provide the cost benefit that they promise.
Well, that's why we're so lucky to have you in our community doing such incredible work on Alzheimer's, and particularly being part of research studies looking at treatment and methodologies for that. And so we appreciate that. The next question I think I could probably start the conversation on, and then I'll hand it off to you, which is, has COVID impacted or escalated Alzheimer's symptoms and things like foggy brain? So one thing that we do know about this particular group of coronaviruses that caused COVID-19 is that they definitely affect the neurologic processes in our body, including those inside our brain. So there's some direct consequences of being infected with COVID. And we see that in young people, not just in older people, where they literally start having cognitive issues secondary to that infection. We also know there are indirect things, which is probably something that you've been dealing with, Cliff, in your practice, which is the social isolation causing people then to have all of the issues that we just talked about. Any other thoughts on that?
Yeah, there's increasing evidence that there is more neurocognitive long-lasting effects from so-called long COVID. We don't know a lot about that yet. It's enough to create some concern. I think we all have to have understanding and compassion for people with persistent long COVID symptoms, particularly the cognitive ones. We still have a lot to learn about that.
Yeah, I will say that I just was on a call with physician leaders from around the state, and we were talking specifically about that we've seen this transition where in the early phases of, quote, long COVID diagnoses, it was usually pulmonary issues or respiratory issues. And now we're seeing more and more that it's really neurologic issues, and particularly cognitive ones. And we think that's a change from what was happening with the Alpha and Delta strains versus the Omicron strain. Still to be more on that. I'll ask you one more question from the group. Do seniors have depression due to aging, or are we seeing more depression in our aging population that was undiagnosed earlier in life?
It's a bit of a myth that older people are more depressed than younger people are. It's possibly true that, or likely true that old people have more depressive symptoms. I would say that is true. Doesn't mean that they're depressed, but they have more depressive symptoms for a number of reasons. They're less active than they want to be because they may have some physical limitations that shrink their universe, so to speak. There's more grief and bereavement because they're losing friends, spouses, family members. And there are changes in their brains that are associated with depression. For example, they have less dopamine, which is a feel-good neurochemical. But it's not true that people in their 60s and 70s who are still healthy are at higher risk for depression. That's actually a sort of a golden time of life, really, in many ways. So I think you have to challenge the notion that old age is associated with more depression. It may be associated with more depression in the old, but not in the younger old, at least those who are still able to maintain independent function.
Well, that's encouraging to those of us who are getting close to the young old category. Dr. Singer, always wonderful to sit down with you. That was such wonderful information that I think all of us can use. I will return the discussion now back to Karen as we transition to discuss how we can assist employees as they decide it's time to leave the workforce and enter retirement.
Thank you so much, Dr. Jarvis and Dr. Singer. What an engaging segment. Such great information, but the delivery was spot on. So appreciate you both. And many of you have already used the question and answer function to ask Dr. Singer questions, but certainly feel free to continue to submit your questions. And we'll do our best to address those questions later on in the program together today. So now it is my pleasure to introduce Jay Pearl, who, like Dr. Jarvis said, will educate us on what employers need to know about Medicare as employees consider the transition to retirement. So welcome, Jay. Thanks so much for joining us.
Thank you, Karen. Thank you for having me. So I really want to focus the presentation this morning on things that an employer might want to be considering. Medicare is a very, very confusing topic for most. And a basic Medicare 101 presentation typically is an hour to an hour and a half. So I'm just highlighting certain things that I think everyone should know. So let me first give you a brief overview of who we are and why I'm part of this presentation today. So our organization is called Carroll Harper and Associates. We're a managing general agency with offices in Bangor, Maine, Portland, Maine, Southwest Harbor, Maine. The company is run by Carroll Harper, the founder of Carroll Harper and Associates. He founded the firm in 1975. So Carroll is in his 48th year in this space. Myself, Jay Pearl, and my son, Carter Pearl, is also part of our team managing the company. So I've been in the business for 35 years. Carter is much younger, being in the business only a couple of years. So we are very focused on the continuation of our company to provide these services in the absence of Carol and myself. So Carter is joined us. We're really excited about that. We have 34 independent advisors that work throughout the state of Maine. They're not our employees specifically, they're just under our umbrella. So we provide training, support, answer their questions. We also personally work with thousands of Medicare beneficiaries to help them with their Medicare insurance decisions. So ultimately our goal, work with good companies and provide the highest level of service possible. Just a brief overview of myself. I've been in the industry since 1988. I went to college in Bangor, Maine at Husson College. It was before it became Husson University. I started in financial services and employee benefits. So I didn't come out of college and immediately decide to become a Medicare guy. That sort of happened. Carroll Harper has always been a mentor to me in our industry, and Medicare sort of found me. I was working with our clients on advisory type services, and I decided to approach Medicare in that way. So we have a very unique educational approach to looking at Medicare, much like you would a financial plan or a retirement plan. So I spend the majority of my time doing presentations. I'm asked by employers to educate their employees and to assist their employees in both Medicare and financial planning. Okay, so we're going to dive into a little bit about Medicare. How does an individual become eligible for Medicare? You become eligible for Medicare one of two ways: becoming age 65, or somebody who is disabled and receiving Social Security disability income for 24 months. So once you know you're eligible for Medicare, how does the enrollment work? If you're already receiving a Social Security monthly retirement check, or if you have received Social Security disability payments for 24 months, you will automatically be enrolled in Medicare Part A and B. No action is required. You're going to go to your mailbox one day and you will find a Medicare card. If you're not receiving Social Security or disability payments, you must be proactive. And you really should start that process 3 months prior to the month in which you turn age 65. Different ways to enroll in Medicare. The predominant one today, of course, is online. Anyone who has created a My Social Security account so that they can look at their future Social Security benefits, you can use that same account and enroll in Medicare Part A and B through it. You can also contact Medicare directly, or you can call your Social Security office. Generally, they're discouraging people now from going into the office, so they'll likely want to schedule a phone interview, and you can enroll in that way. So the initial enrollment period is when an individual first becomes eligible for Medicare. So this period begins 3 months prior to the month in which you turn age 65 and lasts for 3 months after the month of your 65th birthday. So if you enroll during any of the 3 months prior, your benefits are going to begin the month in which you turn 65. But if you wait and enroll in the month of your 65th birthday, or during the 3 months immediately following, your coverage will start the first of the next month. As an employer, one of the things that we are going to be dealing with frequently is what's called a special enrollment period. And there are many, but the one that employers need to be aware of is if an employee decides they want to work beyond their 65th birthday, which, as we've already discussed, many are, they at any time can come off of the employer-sponsored benefit plan in favor of Medicare. This is what's known as a special enrollment period election. So if you've delayed your retirement, remain covered under a qualified employer plan, this SEP election can begin any month. We do encourage folks, allow yourself some time. Don't wait till the last minute, because frequently the Social Security Administration may be a little slow in getting these things processed. Are you required to enroll in Medicare Part A and B? The answer to this is no. If you're covered by a group health plan and that employer has more than 20 employees, what we most frequently see, if somebody wants to stay under the group plan, that's perfectly fine. They will usually enroll in Part A and defer Medicare Part B. The reason people generally will enroll in Part A is that's the part of Medicare that you prepaid during your working years. How does Medicare work with health savings accounts? This is a very, very common question we receive. Understand that if you're enrolled in any part of Medicare, you cannot contribute to a health savings account. Again, if you're enrolled in any part of Medicare, you cannot contribute to a health savings account. Very, very important to understand this. Your contributions must be prorated in the year in which you become eligible for Medicare. If you apply after your 65th birthday, Medicare will generally backdate the effective date for your Medicare Part A by 6 months, but not further than the month in which you turn 65. So when you hear them speaking about health savings in Medicare and how you should stop contributions 6 months prior to, this is the reason why, because they generally will backdate that if you decide to do this after 65. As far as your balance in health savings accounts, absolutely, you can continue to spend that on unreimbursed healthcare, vision, dental expenses, and also Medicare Part B premiums. COBRA. Again, as an employer, we need to understand how Medicare works with COBRA. Medicare does not consider COBRA to be creditable coverage. So Medicare will be the primary payer if an individual is over 65 and enrolled in COBRA. Because of this, an employee should not elect COBRA if they are Medicare eligible. They want to enroll in Medicare when they are eligible. Do not choose COBRA, because in the eyes of Medicare, it's like you had a lapse in coverage. So penalties would apply for a late enrollment, and you don't qualify for a special enrollment period election. Let me talk a little bit about our process. And I think, and this is not just, in my opinion, if you're an employer or an employee and you're looking to figure out what to do in regards to Medicare, this is how the process really should work. What we do, in addition to providing educational presentations for employers, is we'll work with your employees. So if an employee wants to try and decide, hey, is Medicare the right choice for me at this time? We'll have a discussion with that employee. Obviously, employers can provide a resource for their employees, but they can't steer an employee, nor can they give any incentive for an employee to go on Medicare. That's not allowed. So our process is usually to have a discussion with the employee, learn about their particular circumstances. We assist employees with the forms. Now, as an employer, we're all familiar with the Form 5304, which there's documents that we have to complete if our employees decide they want to enroll in Medicare. So we help them with that process. We assist them with enrolling in Medicare Part A and B by computer. Medicare education and plan discussion, typically we do that in person in one of our offices, but we can do it via Zoom or a Microsoft Teams meeting as well. This is when we educate folks as to how does Medicare work, what are the different parts, what are the different plan options. If an employer offers a specific retiree plan program, we make sure that we're familiar with that and understand that so we can have an intelligent conversation with your employee about that. We assist employees with the enrollment applications. And the biggest thing that we bring to the table, anyone can call an insurance company directly and enroll in a plan. We provide ongoing support. So Carol and I both pride ourselves in being able to assist our clients with fixing problems should they arise. So Medicare is, again, a very long and confusing topic. Understand that it's not one shoe fits all. One of the biggest things that I find with folks is they tend to ask their friends, their coworkers, what they did. And hopefully what they did was appropriate and correct for them, but that doesn't mean that that's going to be the best solution for you. It's very, very specific to one situation.
Thank you so much, Jay. Very informative, lots of information. I'm impressed at how you condensed such a complex topic into a 15-minute presentation. So well done.
It's not easy to do it in 15 minutes.
Very well done. So at this time, I'd like to invite all of our panelists to turn on their cameras as we invite the audience to ask questions, and we do have great engagement from you all, so thank you so much. There is a question and answers feature that you can use, and we'll go ahead and get started. And Jay, I'm going to start with you since we have some questions that have been generated throughout your presentation. And the first one is about what is the enrollment process for self-employed Is there a difference from shift from full-time to part-time, et cetera? And you can see that question. I didn't probably do a good job of asking it, but.
Oh, I should click on the question and answer. I'm sorry.
No, let me, you want me to repeat it? I can do a better job the second time. What is the enrollment process for self-employed? And is there a difference for shifting from full-time to part-time?
Yeah, no, the enrollment process is the same regardless of whether you're self-employed or employed by a bigger employer. I will say this, in the state of Maine, we work a little different than what the federal rules state. So federal rule says that if you're an employer of less than 20 employees, that Medicare will be primary coverage. So you should enroll in Medicare Part A and Part B. In the state of Maine, we have some insurance carriers that do not require that, and they'll still cover and pay the claims in the absence of Medicare. So it's specific to the insurance carrier in the state of Maine. Employers can set up the qualifications for whether an individual receives benefits only if they're full-time. Some have benefits for part-time. So that's an employer decision there. So hopefully I answered that.
You did. Thank you so much, Jay. Another question that's asked of our audience is, can you just make sure that we heard you correctly, and that if an employee wants to remain on the company's group health insurance plan after age 65, they can delay Medicare enrollment without penalty. Is that correct?
If the employer is larger than 20 employees, that is correct.
Okay.
If the employer is less than 20 employees, then the federal rule says that you are supposed to be enrolled in Medicare Part A and B, because that will be your primary insurance. You can still stay on the employer-sponsored plan, but that would in turn be secondary. However, in Maine, if you're insured by a plan that's Harvard Pilgrim or Community Health Options or United Healthcare, then they don't require that Medicare enrollment. So it's a very specific situation. I would encourage you to be certain to speak with a professional.
And there's a comment here that there's lots of Medicare Advantage programs. Any, perhaps it's good to kind of, if you're able to give just a brief, what's the difference between Medicare and Medicare Advantage, and how, any advice on how to pick what's right for you?
Yeah, so original Medicare consisted of two parts, Part A and Part B. And people could elect at that point if they wanted to add a supplemental insurance plan. Some people call them Medigap plans. And then when Medicare finally created the Part D prescription drug program, people had to purchase a plan specifically for that. Medicare Advantage plans are contractual relationships between the Centers for Medicare Service and insurance companies. So when you're enrolled in a Medicare Advantage plan known as Medicare Part C, it actually is your Part A benefits, the Part B benefits, the drugs all wrapped together in one plan. And Medicare compensates the insurance companies to administer those benefits. So Medicare Advantage plans, there are many. So it's not uncommon that we might see in a particular county in our state 26 different Medicare plans, Medicare Advantage plans. So navigating that can be very, very complicated. My suggestion is make sure you're working with a professional. Understand you're going to need to share data. You know, to really analyze these plans, we need to understand who you're using for providers, what you're using for medications, and from that information, we can frequently guide you as to what's going to work.
Wonderful. Thanks so much, Jay. Dr. Singer, I'm going to revisit a question that you actually answered typing, but I don't know if all the audience is able to see your response. There was a question asking if you could share more about the research that's underway and if this might inform the issue of an aging workforce. Can you address that?
Sure. So I responded by saying that our research is actually focused on the prevention and slowing of Alzheimer's disease, but we are starting a new questionnaire project a bit of research for the medical staff of Northern Light Health to find out more about their plans for retirement, how long they want to work, what factors are going to influence their decision to retire or to remain in the workforce, and what their attitudes are about older workers. So I think these data will be very helpful and frankly, kind of fascinating, but help guide us, because we have a high percentage of providers who are over 60, and in fact, many are over 70. And we need to plan around their eventual retirement.
Thank you, Dr. Singer. Go ahead.
So there are others in Maine and nationally, internationally, also investigating this, the older workforce. People at the University of Maine, University of Southern Maine too, are thinking about these issues. So it's a big topic though, and I can't steer you to very specifics about that, only what we're doing.
Thank you, Dr. Singer. And Jay, I'll ask the next question of you. Again, it's from the audience, and so I'll read it verbatim because I'm not exactly sure what the acronym within the question actually means. If the employer is larger than 20 employees, but uses an ICHRA option, how does this affect the penalties for Medicare if the employee opts to stick with their ICHRA regular coverage for longer than age 65 before switching to ICHRA Medicare? And you're on mute, Jay, so I want to make sure we hear your response. There you go.
So ICHRAs are becoming a common solution for employers. So employers that are moving away from offering a group health insurance program and instead are setting up these individual coverage health reimbursement arrangements. So what we find in that space is the employers that set these up, the ICHRA is designed to help pay the premiums for an individual health insurance. The issue happens when an employee gets 65, then the marketplace is not an option for them. So the ICHRA can actually reimburse for Medicare plans. So that employee would want to enroll in Medicare, choose a Medicare health plan option, and the ICHRA can reimburse them just like it would for the under 65 individual healthcare.
Great, thank you, Jay. Another question for you. Are you working with employers to advise on long-term care insurance, or is there any trends on this insurance that you know of?
There's a lot of trends on long-term care insurance, and I admittedly will say that I am not the expert in that, but Carol Harper is. He's very well known in the state of Maine for his expertise in long-term care insurance. So I'm happy if somebody has a specific question about that. I may not know the answer, but Carol certainly will.
Great, thanks, Jay. Dr. Singer, I'll go back to you. You know, you obviously have probably, I shouldn't say obviously, the majority of your patients are of older age. What do you believe some of the biggest fears are of the older worker? And do you have any thoughts on how an employer might be able to support an employee to help alleviate some of these fears as they transition to retirement or end of their career?
Yeah, interesting, provocative, evocative question. People worry about feeling irrelevant. They're losing their professional role. They, in some cases, lose a sense of purpose in life. They also may worry about finances. They may worry about boredom. So these are real issues for people. It can, and working full-time and transitioning to full-time retirement is a big step off. And a major adjustment. It can be a real shock for people. That's where the flexibility comes in, to allow people to transition slowly to retirement so they can develop new interests, new skills, new hobbies, and get used to the idea of unstructured time.
Mm. Yeah,
And-
I appreciate that. Go ahead, Dr. Singer. Sorry, I didn't mean to interrupt.
I was just going to say, and then they, they could start collecting Social Security, but still have a working income to build up their nest egg a little bit more and alleviate some of those stressors and make that transition successfully.
Yeah, one of the comments, it was more a comment than a question that one of our audience members made, was around the value of mentorship and having those older workers work with the younger workers. And I can see that that would help give a little bit of job satisfaction and make that be very intrinsically rewarding. But I also can see that that might potentially assist with that transition, knowing that they are leaving a business or a company that they've dedicated years to, and in the hands of somebody who has the knowledge that they were able to help share. I mean, that's just a thought. I don't know if you have any thoughts, but I would be interested just for you to touch upon that concept of mentorship and what that could mean to an older worker.
It's actually one of my favorite parts of my job now is teaching and mentorship. And gaining it's working with younger people, it's obviously a mutually beneficial situation. I learn from them, they learn from me. It takes time to grow into that role. I wasn't necessarily great at mentorship earlier in my career, but I've gotten a lot better at it, and I love it now, and it's an important reason for me to continue working.
Well, thank you so much, Dr. Singer. Thank you, Jay, for joining us. And of course, Dr. Jarvis. Thank you to all of you who were able to join us. It's been a very engaging hour. I really enjoyed it. So it's been an honor to be part of it. Just a reminder, you can find the recordings of all of our Zoom conferences, including today's, on our Northern Light Health website. I hope this hour has been a help to support you, your employees, and our communities. And just a reminder, we will be emailing you a survey right after our conference. And please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on April 13th, when we will offer an educational session on generational differences in the workplace and how a greater understanding of these differences can inform recruitment strategies, leadership, and lead to a more inclusive culture in the workplace. So a great follow-up to today's discussion. We will send you the registration link for this session, and we encourage you to share the information with your friends, colleagues, and others who might benefit. We certainly hope you are able to join us as well. So thank you and have a wonderful afternoon.